Okay, Dave. Hi guys, you're very welcome. If you want to come up to the front, come on. We don't mind people walking about, it's not a problem. So if you want to come up to the front, we've got three really handsome men here, and you might want to get a closer look at them. They're talking this afternoon. Anyway, look, I really apologise. For those of you, I have chaired every session every day so far, okay? And I'm chairing again all the sessions tomorrow. So I do apologise if you've got stuck with me chairing the sessions that you have chosen. I really do apologise, because I usually say the same thing all the time. Dave, you could probably do what I'm going to do now, about the Twitter feed, okay? Hey, we've got our tweeting info DJs. Stand up there, guys. Okay, we've VG and Teresa, and they'll be taking the tweets through the session and feeding back on your compliments and criticisms and questions and comments on our three speakers. Now, this afternoon, if you're a registry anorak, this is the session to be in, okay? If you are a real registry guy, you're in the right place, okay? Now, our first speaker, Robin, is going to talk about registries in Britain. I made a very big mistake when I was chatting to him before the session, because we have a bit about registries in Britain, a bit about registries in Sweden, and registries in the Netherlands. And I said, you know what? And of course, in the UK, our registries are really, really behind those in the other countries. And he was really indignant. So this is his chance to get his own back. Robin, fire away.
Right, hi. Anyone who moved forward in the hope of seeing a handsome man is, I'm afraid, sadly disappointed in my case. I will do my best, though, to make it an entertaining talk, even though I can't dazzle you with my physical attributes. I would say up front, if you were expecting to see Robin Burgess, the Chief Executive of HQIP, the Healthcare Quality Improvement Partnership, I'm afraid he's departed the nest and moved on to NHS England. So I'm going to speak about the national registry system in Britain that I was previously responsible for when I was CEO of HQIP until the end of February this year, and I'd worked there for 5 years. But the views I would express today are neither my views, neither the views of HQIP rather, nor the views of NHS England, where I'm moving as of Monday next week. So, to turn to national registers in England specifically, some of course cover the rest of Britain as well. For those of you who are not from these shores, I won't burden you with the complex details of which projects cover which bit of Britain down to the minute isles of Jersey and Guernsey and all those others. So if I slip into saying Britain, I really mean largely England, although some of these registers do also cover the broader set of islands. Okay, this is what I said I would do when I put my abstract in, so you all have read this, otherwise no doubt you will not be here this afternoon. This is a kind of introduction to registry systems, particularly focused upon the British setting. I would say as a disclaimer, this does not cover clinical trials registries, and I will not talk about those at all beyond this moment. Okay, let's talk about some definitional terms, and I'm afraid I'm not going to give clarity on this perspective. The term registries, or registers, if one wishes to be specific, is a bit of a catch-all term for a wide variety of projects. And no doubt as the three speakers today run through their presentations, some of you will think, is that a registry? Is it a clinical database? Is it a national clinical audit? What is it? And the key point I would make is the paragraph at the bottom there. That you call something a registry or a register or a database or a national audit or a confidential inquiry doesn't actually tell you what it does. These are catch-all terms. You have to look precisely at the kind of things that they do. In Britain, particularly, we tend to refer to large-scale comparative data collection projects as national clinical audits, or NCAs in the shorthand. This is pretty much unique, although audit is a term used throughout the world, particularly in old Commonwealth countries for the British Isles. The term isn't used that extensively outside of the UK and countries like Australia. So when I say audit, you're going to have to bear with me to describe what I'm talking about. So I'm going to go through some definitional work. And just at this moment, my fourth bullet point there talks about confidential inquiries, and PROMs, or patient-recorded outcomes. Now, a confidential inquiry in the UK setting is where cases of particular note, particularly related to death or near misses, are recorded and analysed and then reviewed. Now, some of these have very strong audit or database-like qualities, but they aren't strictly registers in the same sense. And likewise, PROM studies, which are where patients submit their own opinions on the kind of outcomes they've received, are not strictly speaking audit, or they are obviously a form of register, but it's also a form of patient feedback. Okay, am I confusing you? Well, hopefully not. I'll go through into some more detail. Just one slide go by, and I already have to update this on the basis of a very quick discussion just then with one of my colleagues down the front. In terms of registries, many registries in Britain, the comparative registers, are funded by the state. About 60 in Britain all told, about 100 I believe now in Sweden, 50 or so in Denmark, and so on in other countries. These are probably the three countries in Europe that are most developed in having a national system of registers. That doesn't mean to say there aren't lots of registers in a particular country, as we'll no doubt hear about Holland in a moment. But of course, if one looks at the broader terms of what a registry is, there are far more than this. And in Britain there are something like about 250. When I was in HQIP, we did a mapping of as many as we could possibly find operating within the UK, and we were still going at 250 and upwards. Some of those are only regional, but we're roughly speaking talking about those kind of numbers. And I would say the vast majority of those are self-funded, typically by professional or clinical bodies, some by subscription, some by hospitals. But in the main, they're not funded by the state. I think I'm right in saying that the Swedish system has a much larger budget to fund registers at a national level or at county level, which is kind of administrative boundary there. But you'll hear more about that in a moment. Okay, so let's look at the potential of registry systems. There's a wide range of impacts, and I'm not going to read through this vast list. You can look at this in detail later. These are some of the things. But it depends what the project is, whether it can achieve any or all of these outcomes. And depending on the precise qualities or characteristics, it will achieve more or less of all of these things. So let's move on to different types. Let's start, and I'll deal with these fairly quickly, with the vast bulk of registers, which is instance or condition or procedure registries, which typically record the number of people who have had a certain thing done to them or have a particular condition. And there are a large number of these. The important thing to register, of course, is that some of these, because they look at people over a very long period, and I give an example here of congenital anomalies registers or cancer registers, actually are very good at monitoring outcomes over time. So something which doesn't actually compare performance between different treatment interventions is still, by virtue of its longitudinal nature, very much a long-term outcome study. So they are important in that context. And I had responsibility for the commissioning of the congenital anomalies registers in Britain for 4 years. Some registers of this type are of particular value for public health, of course, and they enable the identification of cases, the number of risks, causes, triggers, all these kind of things that can lead to particular types of problems, such as, for example, anomalies. And so they're enormously beneficial for public health, and they're enormously beneficial in terms of planning the kind of volume and type and nature of services. And worth mentioning that some incidence registers are, of course, funded by commercial bodies to monitor post-market the quality of particular drugs, for example, or devices, just as two examples. I'll come back to device registers, talking about one particular group for joint replacement as I go. But I suspect that most of you are not here so much here about that type of register and more about kind of outcome or audit style of registers. And I make a distinction here between the two because there is a very, very clear distinction, and it comes up in these next two slides. Outcome registers are specifically about recording all the cases that have a particular thing and all the interventions that took place in a particular setting, and to see what outcomes were received. These studies, which are sometimes better referred to by their own choice as clinical databases, are not really audits in the sense of comparing practice against standards, not always. And a really good example of one is ICNARC in Britain, the intensive care audit, which is a brilliant longitudinal study which looks at people's, longitudinal in the sense it's been running a long time, looks at people's treatment within intensive care, and is a really brilliant way of monitoring the outcomes of patients in that particular setting. But those types of registers don't always compare practice against standards for care. And so they're not really quite the same as a National Clinical Audit or NCA. Their primary purpose is to measure outcomes, and as well, apart from giving out the data, they don't necessarily do very much to drive change at a local level amongst individuals working in that discipline. That's a crude distinction, and people will say there are all kinds of shades of grey, and of course there are enormous shades of grey between that type of project and national clinical audits, which was the kind of group that I was largely responsible for commissioning. And these do assess the quality of care against clinically proven standards, NICE guidelines, SIGN guidelines, and so on. And they may indeed record all 100% of all cases that occur within a jurisdiction, but they can also sample, i.e. they'll take so many cases, submit that and analyse that on an annual basis, and give a kind of quick snapshot in terms of the quality of care. Although in Britain they are generally moving typically towards a kind of 100% database approach, but not always that. Some may only measure a couple of simple standards and a couple of basic outcomes, so they're still constructed around an incidence concept. But one of their major functions is to promote quality, and very often, as they are owned by professional bodies such as clinical professional groups, in Britain the Royal Colleges of Medicine most typically, or the societies within those, they very much try and drive the quality of performance and activity amongst clinicians from within their memberships. And they take a very active part in that. And that's crucial, as I will come on to talk about when I talk about how one can judge the quality of these systems. Because all of these have various challenges, all of these types of projects, and I'll run through them very quickly here. The level of participation, i.e. how many people send in data, the quality of the data that's sent in, how complete it is, how much it's analysed, how much it's checked, how much it's checked centrally, and so on. The cost of these can be considerable. The kind of ballpark figure per single national clinical audit in Britain is around the £300,000 a year mark, something like 350,000 euros. So these are quite expensive projects. It's also important to say they take a long time to analyse the data and get it to the complete degree of accuracy that one needs to make real decisions based on it. And I will come back to that in a moment. And there's a whole load of time involved, and promoting the findings takes time. Selling the message to clinicians takes a lot of time beyond sending out a report, and that is also crucial. And there's a degree of clinician suspicion about the value of such projects, because they have the fear of risk that they will be named and shamed and poor data put in the public eye, their careers will be ruined and so on. I'm saying this is their fear, isn't necessarily the reality. But there's also very considerable problems to do with research and attribution of effect. And I'll come on to those issues now. When I talk about attribution here, I'm saying, what is the benefit from the audit on the quality of care? And the reality is that, of course, that a monitoring project such as an audit or a register only forms part of a wider spectrum of activity that drives change in a particular area. And I'll give you an example. One of the most successful and effective national audits in Britain is the hip fracture database. And we have done extremely well in Britain in terms of improving the quality of hip fracture care. The time involved in getting people into surgery is enormously improved. But the reasons for that are to do with a range of payment incentives, research, targets, regulatory and commissioner pressure alongside the database that all drive change. So what is it? Is it the audit that's done that, or is it all that wider range of things? Or is the audit just a supporting factor in the broad spread of things that make change happen in the clinical community? And it is important to say is that attributing change to particular small samples on the basis of the audit is really quite statistically difficult to do. And what we really need to do is to go out and systematically and scientifically ask clinicians their opinions. What was the driver here? What made you change your practice in a particular area? Was it the audit, or was it the financial incentive, or was it managerial pressure, or was it professional pressure, or whatever? And ask them to tell us what was the most important factor. But I'm not aware of any such research having been conducted, let alone being published, but no doubt there are people in the room who can challenge me on that. In terms of research, important to say, I'll keep going now, otherwise I'll run out of time. There have been a number of systematic reviews done of registry and audit programs internationally, and a lot of these are very loose in terms of the choosing what type of projects they include within the survey. Remember my distinction at the start between registries, outcome registries, and audits, and they lump them all together and say these are the effects, so this is the value of this thing. And if you read some of these systematic reviews, they are quite ill-defining in terms of what they talk about, the type of studies they include. So one has to look at them with some caution. It's also true, shown in this piece that I cite here by Sue Evans in Australia, that some of the individual studies that they looked at in terms of the overview were actually quite poor in terms of the methodology, and they had very poor rates of attribution and data completeness and case ascertainment and so on. And little study I did when I was at AgeCrypt suggested that actually quite a lot of people on the ground applied some very loose practice in terms of what they chose to do in terms of their own audits. And the attribution is a problem. Getting studies published is a problem. Getting papers at conferences like this is a problem. I think it's the first time this particular conference has covered this in such a large session. Okay. The chair has stood up now, which is my gentle reminder I have 5 minutes to go, so I'm going to speed up a little bit. Just to talk about application though, and this is very current for anybody who works in Britain or is aware of the issues in Britain. Data does take a long time to get right, and if you act on incomplete data to do something like to decommission a service or something like that, you can run into trouble if the data then reanalyzed further down the line shows something different. And all these large projects take a long time, and one has to be very, very careful not to overreact too quickly and to act on incomplete data. And this is an issue that ran throughout the time that I was responsible for commissioning projects, and it's a technical issue that all those responsible for managing this and using this data struggle with all the time. And the issues of Leeds Royal Infirmary and its paediatric cardiac surgery illustrates some of these themes. And I'm not saying that the wrong decision was made to close the unit temporarily on the basis of the data, because it was a very, very difficult technical decision to make. And I'm not being a cardiac surgeon, not able to comment on the rights or wrongs of doing that, but it illustrated all those issues. And again, the very small size of the data sets, particularly for something like paediatric surgery or other relatively low volume areas, does illustrate some of those issues. Okay. So, proven systematic evidence from studies, very, very little peer-reviewed work into the quality of these projects at national level. One example, a study by Larson and all, based around the Swedish model, but also on other studies. It compares different countries against one another. But where there can be success demonstrated is where there are large populations. And the most obvious of those are things like hip, knee replacement, stroke care, hip fracture, etc., where because of the size of the population, you can get your figures more and more and more and more accurate. And as always, the post-market surveillance role. So, very quickly, some likely findings from research and practice. Data needs to be accompanied by feedback. Unless that happens, data on its own will not change behaviour as effectively as it should. The studies by Van der Veer and Flottorp are pretty clear on that. Audit is not just a matter of data, it's a matter of communicating why and how you should change your practice. The Swedish evidence suggests that some publication of data does drive progress. We'll hear more about that, I'm sure. But the primary value of audit-style or national registry projects is probably as part of large-scale national programs of change involving a variety of different elements, which encourage compliance with best practice. So I'll pass over that slide and conclude with a summary that, in the main, national registries are very, very high quality data indeed, probably the best you have available. And it does enable you to have very large, reliable data sets to tell you something about a range of things, including, of course, patient safety, which I have no time to really talk about, individual clinician performance review, particularly of surgeons, and also to drive quality improvement. But they should form part of a wider and broader cluster of data indicators. For more information about the British system, go to the HQIP website, which is given there, and I give a set of references that I've mentioned whilst I've been speaking that you can look at when you look at the slides. Thank you.
Great, Robin. Thank you very much indeed. That's super. Maybe balances up a little bit my comment on the UK registers. But anyway, actually, you made a comment there I should probably respond to, and that is about publishing work from registries. I'm Donald Macaulay. I'm one of the BMJ editors, and I spend a lot of time reading and assessing research papers. Now, the bad news for you guys in terms of registries are that in the BMJ, we are not interested in publishing a registry study unless there is a research question. Now, we do appreciate the huge amount of effort that goes into the registries. We appreciate the incredible value, particularly in patient safety. But as a research study, the key is, what's the research question?
Yeah.
And I can appreciate that people looking at registries get upset because of all the work that goes in. Now, the other thing you mentioned about the difficulties of publishing audits, we don't publish audits. Now, every rule can be broken, but in general, we don't publish audits. And in general, we would only even consider an audit if there was a full audit cycle. So anyway, sorry to be kind of disappointed for those of you who are thinking of the BMJ, but there are lots of many other journals who are interested in that type of work.
But that's a very significant point, because that distinction between audit or registers and research is quite crucial. Certainly in the British system, an audit is never research. Now, I know that there's a grey area, and of course you can reanalyse the data with a research question in mind and get published on the basis of that. But on a priori basis, audit studies are not going to get published in one of the major journals, which is a shame.
Yeah. Now, it's great fun, you and me chatting up here. Anybody else want to join in? Any questions from the audience?
Must be one.
Okay, well, there's one question right at the very back. So we'd have to get Teresa to sprint down, and while Teresa's sprinting down, I'll actually let Richard come, because I think we've only time for one question. Robin, you come down, we'll let Richard get his slides organised.
Can I not get my question?
Yeah, you are, you're going to get your question, but we're going to talk about it down here while Richard's getting organised, because we want to keep absolutely rigidly to time so people can make the... Teresa, I don't think you're as fit as your colleague here. You're a bit slow getting down there. Okay, fire away.
Thanks very much, Robin. That's really interesting. And I'm afraid this isn't really a question, but a bit of shameless self-promotion. I'm Liz Clyde. I'm an implementation scientist at Leeds University, and I'm funded with Simon Stanworth, who is leading a programme of research over the next 5 years that's going to be using psychological theory to try and understand how we can improve the modest effects of audit and feedback. So what we're going to be doing is working with blood transfusion audit programme that's funded by the NHS, and we're going to be looking at building systematic interventions that split the delivery and the content of audit and feedback messages, and trying to build interventions and then conducting 2 large randomised controlled trials over the UK. So it's just, there is some evidence coming, but it's nice to know that there is a big gap that we're going to fill, so thank you.
Well, Robin, that was shameless self-promotion, you're absolutely right. Anyway, look, thank you very much indeed. You did mention the 3 magic words, randomised controlled trial. And certainly in terms of implementation science, we would be interested in those 3 words. Thank you very much, Robin.